it looked like you had a slideshow ready.
No, that was just the warm up.
Okay. Okay. All right. So yeah, like Chief mentioned, tonight's training is on capnography. I'm gonna go over and share my screen. Let me see. How do I do this? All right. Got to go into my settings here. Sorry.
Also, Andrew, don't do it like I did and forget to stop the video at the end, or the recording at the end.
So it did come through. So even if you forget to stop it, it still emails it out.
Okay.
So, dumb question: has somebody started recording?
All right.
I did, yes.
Is everybody able to see my screen here?
Did you say you did, Jamie?
That's correct.
Okay. Yes.
Okay. All right. So this is the slideshow. Just let me know if any of y'all can't see it, if I need to change anything.
Maybe go full screen.
Yeah. How's that?
That'd be better.
All right. So it's on end title capnography, which is right now something that pretty much only medics are doing, but I know many jurisdictions are expanding it out to be a BLS skill. I think even National Registry is. So it's certainly not something beyond the scope of BLS providers. It's extremely useful, and I hope to one day see it, as the standard of care for ALS and BLS. So just to kind of get into a background here, obviously we got to know what the word means if we're going to be, doing this procedure. It's pretty simple. Broken down, it's capnography. So basically, capno means it comes from the Greek word smoke. It means carbon dioxide, and graphy is just a graph or a written version of something. And by smoke, what they mean here is carbon dioxide, which is the major byproduct of any form of combustion, whether that be in the cells or from a literal fire. So essentially, all this word really means is a visual representation of smoke or carbon dioxide. And then the word end tidal just means it's at the end of a breath. So the word tidal, as far as respiratory physiology, is like tidal volume, which is the amount that you breathe. It's just a word that means the breath. So the end of the breath is when it's measured. So like I said, we're measuring CO2 or carbon dioxide. Basically, that all that is just the byproduct of cellular metabolism. So you breathe oxygen in, you breathe out CO2, and on a more micro level, inside the cells actually use that oxygen and then produce CO2 as a waste product. It's exhaled so it's carried through the blood into the lungs, and then it's exhaled, which means that the air, so to speak, that you breathe out is actually composed of a pretty good amount of CO2. Let me see here. So why do we care about CO2? Basically, like I said, it's the the exhaust from the engine, so to speak. So if the cell is an engine, the CO2 is the exhaust. So we can see by looking at the exhaust, we can see how the engine's running. So, in this example here, in these two pictures, there's a tractor that's probably putting out 200 horse, and then you have a big diesel locomotive that's putting out, maybe 2,000, and you can see the difference in the smoke. And, this is certainly it's a parallel. It's not doesn't exactly work the same way, but it's a pretty good analogy. So, clearly you can see the train is putting out more smoke. It's running harder than the tractor. And so not only can we see how hard the engines are running, we can also see how the smoke is coming out, which can show us how the exhaust pipes work. So, and I think it's important to think about it simplistically like that, because, there's a lot of terms and a lot of, stuff that kind of gets into the nitty gritty, but the reality is that it's not really that hard of a concept if you think about it like the exhaust from a motor. So what we're going to get into first is capnometry. Capnometry is actually the numerical value. So if you look at the monitor, it tells you a number and then it shows you a waveform. So capnography is the actual measurement. The waveform is just a visual display of kind of how it's coming out. So this right here is our standard LifePak monitor, and over on the side, you got all the kind of readouts for everything. You got the pulse rate, the pulse ox, temperature, blood pressure, all that stuff, and the end tidal CO2 is one of the measurements on there. And then the waveform at the bottom there shows the actual waveform of the CO2. So in this section, we're just talking about the number here for now. So the CO2 is, the normal value is 35 to 45, and that's measured in millimeters of mercury, which is the unit. So to break down basically the three major causes that can drop that value, there's three things. So the first thing can be, and over here on the left is shock. So just to kind of give an introduction, picture these factories like the cells. So the factory is big here on the left side, and then there's a little arrow, and then the factory is small. So what that's showing is that the factory is partially shut down, and as you can see, there's less smoke. So when you start to get into a shock state, the cellular metabolism slows down. So you're not going to be producing as much smoke. So in typically this is in the later stages of shock. And this is compounded by the next section here. In the middle, you can see there's a fan, and that's blowing away some of this smoke. So this measurement here, if you look coming right out of the smokestack, is lower. There's less smoke because the fan blew it all away. So this is from hyperventilation. So if you sit there and breathe rapidly, it'll cause that. But this can also be from a profound metabolic shift in the body that causes the person to try to compensate with their respiratory system and blow off too much of that CO2. And that can happen from acid-base imbalances and a lot of other things. But it's certainly another cause. So just think of it like, you're blowing the smoke away. So just even your standard, person who's having a panic attack and hyperventilating, they might have a low end tidal CO2. And then on the right side, you can see the cardiac arrest and how end tidal plays a role in that. If the end tidal CO2 is low, because remember what this is a representation of how that factory is running, or that motor, or whatever analogy you like to use. If the motor is running poorly, then you're not going to get much smoke. So if you're looking at it and you see the smoke and there's it's a low value, that could mean that your CPR quality is bad, because even though you're doing it, you're not able to perfuse the patient's cells. You're not able to get that factory going. So what that means is that maybe you need to increase the depth or the quality of your compressions. If let's say you get the Lucas on, or you're doing great CPR and the end tidal CO2 is still low, that indicates a bad prognosis for that patient, because they're refractory to all the efforts that you're doing. They're super, super sick. And that's actually one of the criteria we use for termination of arrest at the ALS level. So when the end tidal CO2 value is low, think about a metabolic problem like shock or hyperventilation. Now, when the end tidal CO2 is high, that means that your body's holding on to that smoke. So typically, this is from a bottleneck. So if you think of these exhaust pipes being stopped up, that CO2 builds up, and so the number's high. This bottleneck can be a physical narrowing of the passages, but it can also be a reduction in the airflow, not by a physical, obstruction, but a reduction due to a lower volume of air passing through. So if the respiratory rate slows, you're having less air moving through, less air carrying that exhaust away, that CO2 away. So it builds up, so you get a high value. So when end tidal CO2 is high, think about CO2 being built up because it can't escape or it can't be carried away. So in this picture, you see a healthy lung over here on the left side, and you can see this airway passage is nice and open. And then on the right side, you have a lung that's inflamed due to asthma, COPD, anaphylaxis, any kind of reactive airway disorder. And you can see that the airway passage is constricted. So what's happening here is that the CO2 is still being produced because the cells are still running. It's just a matter of it can't escape. It builds up, and so this is going to cause your value to be high. So if you see an asthmatic, they could have a hard time getting CO2 out. They're building it up, and they have a sky high end tidal CO2 reading. So again, when the end tidal CO2 is high, think reactive airway disease or hypoventilation. If someone hasn't been breathing or they're only breathing 4 times a minute, maybe they overdosed on an opiate, and they could have sky high end tidal CO2 because they're not moving enough air out to pull that CO2 away, so it's building up. So another thing we can use capnometry for is determining ROSC. So if you picture a patient you're doing CPR on and the end tidal CO2 is 15, and then it suddenly jumps to 45, this could mean that the cells have started running again, started functioning on their own, and so now you're back up and running. So if you see these pictures here with the end tidal CO2 being 15, let me go back. With the end tidal CO2 being 15, you're not really getting a whole lot of cellular metabolism going on. But then over here, when this metabolism starts back up again, the number could be 45. It could even be higher due to residual CO2 that's been built up over a prolonged period of time. But if you're working a cardiac arrest and the end tidal CO2 jumps, that's an indicator of ROSC. So using capnometry in the real world, practically, it's a great tool if you're ventilating a patient with a BVM. It's a great tool to adjust or to fine tune your ventilations. So over here, you can see kind of a spectrum. And so, like I said, we want to be between 35 and 45, which is normal. If you're not bagging fast enough, if you're bagging too fast, you're going to be blowing off that CO2, and you start getting below 35, you want to bag a little slower, stop blowing it off. If you're above 45 and it's building up, you want to increase that rate to try to move some of that CO2 out. And just remember that this is a way to adjust your ventilation. It's not, you shouldn't base your ventilations 100% off end tidal CO2 because they could be super septic or something like that. And, now you're not ventilating them correctly. So it's just a kind of guideline to be able to make adjustments. So if you're bagging somebody and everything's good, you're hanging out at an end tidal CO2 of 40, no need to change anything. But if, maybe you're bagging them every 6 seconds and, CO2 is up to 50 or 55, maybe bag them every 5 seconds. So the other use for capnometry is a head injured patient. So we use what's called permissive hyperventilation. If somebody has a head injury with herniation, which means the brain is swelling from such a high amount of intracranial pressure that it's causing herniation, which is when the brain gets squeezed through the different holes and the different openings in the skull, and that's seriously bad. And you'll know that they're herniating when they have things like seizures, posturing, which can be pulling their arms toward their core or spreading their arms and legs out. You'll see irregular respirations, you'll see blown pupils, things like that. And most of the time, these patients will need ventilatory support. So when we're doing that, we're going to permissively hyperventilate them. What this is doing is you're intentionally blowing off CO2 which causes the cerebral vasculature to constrict. And so that constriction actually reduces the pressure inside the brain. Remember, the skull is a closed box, so if the brain swells, there's not really a lot of room for it to go. We got to be careful doing this, though, because, as good as it is to, reduce that swelling, to, reduce the blood flow, we're also reducing the blood flow to the brain. So, it's a good thing and a bad thing. We have to be very careful doing this. And the best way to do that is to use an end-tidal CO2 target. And we're just going to target the low end of normal. So we're going to 35 to 40 instead of 35 to 45. And this will allow us to get, hopefully enough vasoconstriction to slightly reduce the pressure without doing it so much so that we're cutting their brain off of oxygen. And it's an extremely fine line to walk. And that's why it's important that we use our tools correctly to accomplish that. So the next section here is waveform capnography. This is the actual picture that you see. And to be honest with you, this is less important. This is telling you how the exhaust is flowing out. And you already know with your assessment tools, lung sounds, looking at the way somebody's chest is moving when they're breathing, whether they have pursed lips, things like that. This tells us what we already know. But it's a great assessment tool to have, and it's certainly part of a good assessment. So what we're looking at here is the waveform of how this CO2 is coming out. Like I said, picture it as if we're looking at the readout of the exhaust, and it's kind of contradictory to what would be intuitive. A lot of people would think that the spike here is actually, the spike and then the plateau is actually a breath in. But remember, this is looking at the air that you're breathing out. So the initial spike is exhalation. The middle part is kind of you breathe in, you breathe out, you kind of hold it a little, and then you breathe in. And that's the downward spike is the inhalation. You breathe in, you have a full breath of air for a second, and that's your baseline, and then you breathe out, and that spikes it again. So a normal waveform will be square looking because nothing is impeding the flow of that gas. So it's just your typical, you hold you take a full breath, you hold it for a second, you blow it out, you sit there a second with empty lungs, you take a deep breath in, and it's a nice square box looking waveform. This is the most common abnormal waveform that you'll see. This is it's called a shark fin morphology or a shark fin waveform. And this is a evidence of bronchospasm or any kind of reactive airway disorder like asthma or COPD. So what we're looking at here is the corner on that kind of square waveform has been rounded off or flattened. And what's happening here is that because those airway passages are tight, and if you remember that picture that showed the lung all swollen up and inflamed, it's a harder passageway for that CO2 to pass through. So it builds up and it's harder for it to get out. Remember that exhalation is a passive process. So basically the only thing causing exhalation is the natural return to equilibrium with the pressures, because when you inhale, the pressure in your lungs is higher than ambient pressure. So that exhalation is not only not caused by the diaphragm muscle, it's against a more resistance than usual. So what you're seeing is basically as that corner on the morphology is flattened out, you can see that the CO2 is having a harder time getting out of the lung, or in other words, the exhaust is having a harder time getting out. And so that shows you that the patient's lungs are inflamed. So this is a indicator of asthma or COPD or something like that. And the inhalation side is pretty much unaffected because asthma is typically an expiratory problem. So this next waveform shows rebreathing. This is when you don't exhale all the way. You keep breathing, and then you take another breath, and it's called, another word for it is stacked breathing. So you're continuing to take deep breaths without a return to baseline, without emptying your lungs all the way out. So you'll see the corners and everything look good, the intervals look good, but your exhalation, or excuse me, your inhalation never returns to the baseline. So extubation is something that's a serious problem. One of the largest things that we can do that can harm a patient. If a patient is being ventilated through an endotracheal tube or a King airway, they're basically in a state where they have no control of their own breathing. They're extremely sick and extremely sensitive, and so they can't tolerate that tube being misplaced even for a short period of time. So we need to make absolutely certain that every single breath that we give them is going into the lungs. The way we do that is with looking at the end tidal CO2 waveform. So every time you squeeze that bag, you're going to get one of these square waveforms, like I said, that indicates a breath. Remember, because the upstroke is on the exhalation, you're going to see that when you let off the bag, and then you're going to, as you squeeze the bag again, you're going to see that next dip, and so on. If suddenly you're ventilating your patient, everything's going good, and then suddenly you stop seeing a waveform, you just see nothing, you see a flat line. This indicates that you're not, that the air is not coming back out of the tube. The exhalations are no longer coming out. And if the exhalations aren't coming out, chances are the inhalations aren't going in. So that means the tube is no longer patent, the line is no longer good, which means that the tube needs to be troubleshooted. You need to determine where that tube is, and why you're not getting air exchange. Because if your tube is not in the trachea, that patient will not be breathing. So this last one here shows spontaneous respirations. This is called a Curare cleft. If you're ventilating a patient who's apneic and you see these clefts here, what this represents is actually that the patient's taking a breath against the ventilation that you're providing them. This means the patient is most likely emerging from the sedated state that they're in. So whether this is from a rapid sequence intubation where you paralyze the patient and now the paralytic is wearing off, or whether your patient was severely hypoxic and now they're getting some more oxygen in, their brain's getting perfused more, and their body's starting to take over some of their own, regain some of their own functions. They need more sedation or paralysis to make sure they don't start bucking the tube and fighting the ventilations. So this would be a time when you see these on the monitor, would be a time to determine exactly what the specific circumstance is for why the patient's spontaneously breathing when they were previously apneic. And then at that point, you can determine the best course of action. Normally, this is an indication for a sedative. So the next thing I'll show you before we get into questions is some basic equipment. The two ways we measure it is with nasal cannulas, and this is what it looks like here. There's a reservoir here, and this actually sits over their mouth, and there's prongs in their nose, and this captures their exhalation. This is how we can monitor it on a patient who's not intubated, and this can go under a CPAP mask, under a non-rebreather, whatever. The next is an inline capnography. This goes on all intubated patients, anybody who's receiving breaths, ideally anybody receiving breaths from even a BVM, but this goes between a King airway and the BVM, or the mask in the bag, or an endotracheal tube in the bag. And this other side just plugs into the monitor. So at this point, we can open it up for questions if anybody has anything.
Andrew, this might be a stupid question, but you were talking about the spontaneous breathing.
Sure.
You can't take the tube out, correct?
Well, it's a decision for the medic to make. I don't believe in hardly ever doing that. You know, I think if you had to intubate them, they should probably stay intubated. But you know, that would be it's a good question, because if they start breathing on their own, they might start fighting the tube. And then as the medic, I would have to decide, do I want to sedate them against this tube, or do I want to pull the tube and let them manage their own airway?
So you can do it yourself. You don't have, I mean, do you have to consult for that, or is that?
No, I could, you know, I can't, I don't carry any paralytic drugs, but I carry sedating drugs. So I could give them a medication to basically calm them down and you know,
Get to the hospital.
Yeah. So it would reduce their, the pharmacology behind, this is basically anesthesia. So the pharmacology behind this is kind of, you know, gets, you know, kind of nitty gritty. But the basics of it is that, yeah, you could, at that point, if they were breathing on their own, you could decide, you know, maybe they were a cardiac arrest patient, you had them intubated, and now you got them out of cardiac arrest, and they're coming around, they have pupil responses, they're starting to, you know, move their hands, stuff like that. You could say, okay, we'll pull the tube out. Or, you know, maybe they have a bad head injury, they were hypoxic, you know, you got their SATs up, so they're starting to regain some of their own bodily functions, but you really don't trust them to manage their own airway. At that point, you would give them medicine to sedate them more, to put them into more of a state where they would tolerate your tube being in their, you know, in their throat.
Yeah, I just don't know very much about it, just because, I mean, when I first learned, we had the EOA, so, and that was a basic skill.
Yeah.
But back then we were not allowed to extubate.
Yeah, it's it's one of those things where it really is a tough decision, and it's not, unfortunately, it's not something I can say black or white. It's there's a lot of factors that go into it, but I would say by and large, most of the time, the right call is to preserve that airway and give them medication to stop bucking your tube or fighting.
And I actually second that. And, you know, I spent all this time securing that airway. Unless the patient is awake and pulling it out themselves, I'm probably not going to extubate. And I would consult just to confirm.
Thanks, Jamie and Andrew. I just, like I said, my only experience other than the medic doing it was, you know, 30 years ago when we were allowed to do EOA tubes.
Right. But it's great for you to know this, because to be honest with you, you know, on a call like this where the patient's intubated, where there's a lot going on, the medic might not notice this. So if you say, hey, look, the patient's breathing on his own, you know, I see a coronary cleft, you know, if the medic even knows what that is.
Right.
But they might say, oh, wow, you know, thanks. Now I can be one step ahead when he does try to buck the tube here in a minute, or whatever the case may be. So it's, you know, I think it's great for EMTs to know, you know, what this stuff means, even if they're not intubating.
Well, just like you guys were talking at the beginning of this, you know, these skills might be above myself or Bill Hoxie, because we're just EMTs. Not that we're just EMTs, but if we're riding with you guys, which I prefer to ride with a medic, you know, I will at least be able to know what these things mean.
Yeah, certainly.
That was an excellent presentation. I know, like you said, it's not a skill in Maryland. It is a skill in Virginia, but I'm flabbergasted when, you know, after attending another class on tidal CO2, and we're doing CPR, we could actually see the waveform, read the numbers. It just blew my mind how it's such an effective tool for helping for doing breathing and CPR. So it's definitely cool.
Hey, Barry,
I really appreciate it.
I don't think that I'm questioning. I believe it is a skill in Maryland.
I'm pretty sure
See,
I
that's
had.
been so I went up to a class in Ocean City on this. Yeah, so I attended a class in Ocean City on this. So several years ago, when I came back, I remember we were talking about this, and that's when we started buying the entitled CO2. But yeah, I guess the point is that if it's just BLS, we do not have the capacity to use the entitled CO2 because we don't have the monitor to accept it.
That's the
I
only
don't know
limit.
if that's what
That's
places.
the only limitation.
Right.
It is a BLS skill.
It is great.
I'm almost positive I had a question on it on my exam. My national
Yeah, I'm
registry.
sure you did. Because
Yeah,
I know we
in
practiced
National
it down here.
Registry, It
Yeah.
is BLS.
Right.
It is a BLS skill.
Is there
Right.
end title on the Life Pack 12s in the ambulance?
No.
No.
Well, yes,
There
The
is.
old ones?
yes.
So then, I mean, if
The
it is a
reports there?
approved BLS skill, that would
Yeah.
be your opportunity to use it.
So David,
You're breaking up, Barry. You're breaking up.
Barry, you sound like a robot.
You can't hear anything, Barry.
Well, I remember, Dave, you and I ran a call together and you explained it to, we had a student on the crew, and it was you and myself and a student. And I remember you explaining it to us that night, but seeing how Andrews showed it, it really makes a lot more sense now.
Yeah, but that's not the point.
Right.
The point is it a BLS skill? And the answer is, I am sure it's a BLS skill. In fact, I'm looking it up right now.
Okay, that. Because that's been a big discussion.
Well, that's because you keep discussing it. I'm pretty sure it's a BLS skill. I think it was released to BLS about 2 years ago. Really, seriously. Let me find it.
I'll look
I was taught it. I was taught it to get my license, and I saw it on the test. So I know for a fact also that it is a BLS skill.
Yep. And it's a question of how you use it. There's nothing that stops a BLS provider putting on a end-tidal CO2 cannula. And the only thing that we would question would be, what are you going to do with it when you got it on there? But I believe that otherwise it's a BLS skill. Hang on. We're just downloading the protocols.
Yeah, well, that's certainly something we should absolutely look into. And
But I think we have. I mean, that's why I'm trying to find it now, because I hear this said. This is more than once it's been said, and more than once we've challenged it, and I believe it's a BLS skill. I think now, can you use it in intubation? No, because intubation itself isn't a BLS skill. But is end-tidal CO2? Yeah, sure. Okay.
So going back to the other question today, did we confirm, did our Light Pack 12s have the port for accepting that?
They do.
Okay, I didn't think they did. I thought that's what we're going to discuss. Okay. All right.
yeah, I don't know.
They do.
Okay, you say so.
I mean, they do.
I mean, I was told no and no.
showed me how to use it once on that pack,
Right.
but I don't remember how to do it. It was a long time ago.
They were specifically updated about 5 years before we got Life Pack 15s.
Okay.
So what I'll do to keep you from having to search and search and search, I'm having a protocol update meeting tomorrow. I'll just ask the question.
That'd be great.
We're discussing the protocol release.
Great. It'd really be cool.
I mean, the issue is not so much whether a BLS provider can put on and take an end-tidal CO2 measurement. You can. The biggest issue is, what do you do with it when you've got it? And how do you get it in the first place? Because most people don't have life packs, or even more so ETCO2 machines, because you can have separate ETCO2 machines. But in terms of it being a skill or not, I think that was changed about 3 years ago.
Okay.
Yeah, what I was finding was 2017.
Do what now?
I Googled it, and it comes up that it's a protocol from 2017.
Yeah.
Okay, good. Because I remember going to class and it up in Ocean City, and that'd be right about the same time.
It was changed about 2 years ago, 2 to 3 years ago. And that's why we started. There was actually about a year when we stopped using the $6 cannulas, and we
Right.
only purchased end-tidal CO2 cannulas.
Right, I remember that too.
Right. Well, there's a reason why we did that, because it became a BLS skill. And the reason we went backwards is because it is the difference between spending $5 to $6 per patient compared to $25 to $30 per patient, when 90% of patients don't need end-tidal CO2 measurements.
Right, I remember going through that also.
So the reason we did it was a financial issue,
Right.
but it absolutely is a BLS skill.
Okay.
In Maryland.
Okay, good.
Yeah, and it also says that GEM started it in 2012. GEM started pushing it as a BLS skill in 2012.
Right, but it still comes down to Maryland, right?
Yeah,
I mean,
no. I'm saying
Right.
Maryland was 2017, but GEMS was 2012.
yeah, and very few people use it at the BLS level, because you've either got to have a life pack with an end-tidal CO2 interface, which we have, or you've got to have an end-tidal CO2 monitor, which we don't have, and which would cost about $6,000 per ambulance. And we don't carry it because the reason we don't carry it is because you're likely to have an ALS provider, in the sense that the ALS provider isn't going to be interested in that device, and they're going to have their monitor there. So we don't put them on as separate units. But in terms of, can you put it on and can you interpret? The answer is absolutely you can. It's a BLS skill, definitely.
So Andrew, while we're describe, since I think we've buried this question, on just so that everybody else knows on the BLS side how to install the port onto the light pack. You know, some people think you just pull it in and out.
So it's a, oh, this doesn't have it. Let me pull it up here on Google. So if you see this orange thing, this screws in.
Right.
And the life pack has a, I hope I'm still sharing my screen. Can everybody see this?
Yep.
Okay. So the life pack has this little flap up here at the very top, and it's even labeled CO2. You
Right.
lift that up, there's a hole, and then this screws in.
Right. Yeah, about like a quarter turn.
Yeah.
Very
Yes,
gentle.
it screws. We've already had to replace one of these this year because somebody pushed. It's not a push, it is a screw.
Yeah. It's just a, yeah, it's like a half turn, and it just goes into place.
So the other thing I would add is that the most common, I think the most two common BLS uses, and you could extend it to three, but the two most common are somebody with asthma, or you're looking for a shark fin. So say, for instance, somebody has a history of asthma, or you've got a child with trouble breathing, and you decide that, you know, you can still give them oxygen, either through a non-rebreather. By the way, you can put a non-rebreather over the top of a nasal cannula. There's no reason why you can't do that. You can do both. So you can get a end-tidal CO2 onto a child, for instance, that's got asthma, and you can see shark's fins. That's very useful, right, in the sense that it tells you you've got an asthmatic patient. Not that you probably haven't worked that out already. The second thing that it's mostly used for in BLS is when you're bagging a patient that's in cardiac arrest or that needs ventilatory support, working with an ALS provider, and you're bagging that patient, and while the ALS provider is busy doing whatever they're doing, your target is to adjust the bag depth and the bag rate in order to try and keep their entitled CO2 in the 35 to 45 range if you can. Now, if you find that suddenly, so you're watching the monitor, you're watching the rate that you're bagging at, you're trying to keep that CO2 level in that target zone by altering the rate and the depth. And usually it's very, very gentle. It's quite a delicate skill to get there. And you suddenly see that number go 55, 65, 75, 80, and everybody else is still doing what they were doing. What do you think that is? What does that tell you?
You're being too
You're bagging too
fast.
fast.
Right.
It actually tells you that you just got ROSC. So that the first
Actually, I have
indicator,
a perfect example of that. I actually have a printout. If you give me 2.5 seconds, I'll show you.
right? The first indicator of ROSC is that you see your entitled CO2 go through the roof. I've seen them go to 80 to 100. And the reason that that happens is because suddenly the heart starts beating properly, or reasonably properly, and all of that CO2 that is built up in all of the cells throughout the body is suddenly available to be blown off through the normal ventilation process. So you get a sudden glut of CO2. And that is the single most obvious, immediate example of the fact that you've got return of spontaneous circulation. Very, very important sign.
Jamie, I'll go ahead and stop my screen sharing so you can put your camera up.
So this right here is, sorry for the kid. This is an intubated patient in refractory VFib. We just intubated them. You can see that waveform is upside down. This is at shock 7. On shock 8, you can see the immediate change in the waveform capnography. And how it jumped. It's actually jumped up above 30. And that's how we knew to check.
So very, very, very critical. I mean, and that's extremely useful in a BLS provider, in a cardiac arrest situation, in an ambulance. If you see that capnometry number change, so your capnography, right? Graph is graph, metric, meter, number is capnometry. So when you see the capnometry number bounce and go way off the scale, up into the 90s, 80s, 90s, 100s, and nobody else has noticed it, that is an extremely good indicator of ROSC. I mean, would you agree, Andrew?
Yeah, the one other thing I'd like to add is that it's, I would say, a phenomenal part of your sepsis workup. So if you look at the protocols, the sepsis criteria says one of the things you can use is an end-tidal CO2 of less than 32. And remember this because, if you're in a shock state, your cellular metabolism is diminished. And I have an interesting story. The other day I ran a call for it was a stroke call at the Genesis or something. And we get in there and, it's a lady who's, altered mental status, borderline tachycardia, but she was on all kinds of blood pressure medicines. So, her heart rate was probably artificially lower than what it ought to have been. Her pulse was a little bit weak, a little thready, but not too bad. And the way her mental status was certainly seemed more like a stroke. But, as part of my workup, I put her on capnography, and I actually did that before I even got a blood pressure reading back, as the monitor was cycling. And so before my blood pressure even returned, I knew that, I saw the end-tidal CO2 was 20, which is extremely low for someone who's alive. And I knew right then and there that it was a priority 1 sepsis patient, not a stroke. And, you know, sure enough, blood pressure came back in the 80s, but I didn't even need that. You know, I think by that point we were already rolling down the road knowing it was sepsis. And end-tidal CO2 is a phenomenal.
And that's absolutely right. You remember I said there were 3 reasons why a BLS provider would use it? That is the third and probably most important, because how many times do you end up as a BLS provider on a BLS call, sick call, and you get there and exactly that scenario that Andrew just came up with, but you don't have an ALS provider because it's just, you know, mum's feeling sick today, right? And if you had capnography and you put it on and you had a reading of 20, you know that you've got a priority 1 sepsis.
Right.
And you can tell that straight away. I mean, it literally is like, it's like putting a big neon light over the top of them. And if we taught our BLS providers to look for that, that would be one of the most useful things that you can do with capnography. The first one, in terms of the restricted breathing, well, you can hear it. You can hear it, you can put ears on, you know whether somebody's got asthma, you know whether somebody's got restricted breathing. You're not going to, it's interesting to see the shark's fin because it kind of confirms stuff and it indicates what's actually physically going on. But frankly, you know what's going on before you even start to put something on them. You're giving them oxygen, you're going to try and open up their bronchi and get more gas exchange into their lungs. The second is very useful if you're on board of a unit with a cardiac arrest and you're the one that actually is paying attention because you're watching the screen to try and keep your bagging rate and your bagging and your end-tidal CO2 in the right zone. So your eyes are on it. Everybody else is trusting you to bag. So you're going to be the first person that sees that peak on the capnometry number. So that's a really useful skill too. You can be extremely valuable, right? And the third one, the one that really matters, is when you're on your own and it's a BLS call and nobody's thought about calling ALS yet because it's just a BLS sick call. If you had capnography at that point and you put capnography on because you suspect you've got a high temperature patient, they're tachycardic, could be a stroke, you're kind of trying to think it through. You put capnography on them and they sit in a 20, but they're still moderately conscious. You know you've got sepsis. And you can declare a priority 1 sepsis straight away and be on the road. So that's how you use it, right? That's the value to a BLS provider. And that's why they brought it into BLS protocol.
So let me ask a different question, because I don't think I've ever heard the answer to this. What about a person who's has been inhaled smoke, you know, from a fire? What would you see with it there? So
the capnography is looking at carbon dioxide, not carbon monoxide.
Right.
Actually, they're separate.
I'm just asking.
So basically what you see is a normal waveform as long as
okay.
Normal. You'll actually there's a pulse ox that could go on the finger that can pick up the saturation of carbon monoxide, and then there's also a kind of like a breathalyzer type device that picks it up. Similar methodology to how the end-tidal CO2 detector works, but unfortunately the one that we have only does CO2.
Yeah, there's a reason for that. And you're talking about rainbow sensors, right? Yeah. So with rainbows, we used to have rainbows. And the problem is that I think a rainbow sensor these days is about $800. And it got torn up on a routine and regular basis. So that got a bit expensive. And folks didn't most of the time know what they were looking at anyway. So we had the choice of going with just O2 or rainbow. And we decided to just stick with rainbow because the number of times you get a carbon monoxide patient is very rare.
Yeah, and realistically, it doesn't change the treatment. So
No, you'd still just flood them with oxygen. So it's all very interesting to know, but is it worth $800 to keep our rainbow sensors intact?
Right.
No, not really. The other thing with rainbow sensors is that they are affected by fluorescent lights in the vehicle, so you can get false readings.
Actually, I believe you might actually see a low EtCO2 in a carbon monoxide patient because they're going to be hypoxic because they're going to be hyperventilating, trying to off-gas that monoxide.
right, if it was, yeah, that could be, and I'm sure this, this is all situation dependent. But I guess the main thing to remember is that carbon monoxide and carbon dioxide behave differently in the body, and they're not necessarily correlated. So certainly if there's a condition where they're hypoxic and they're increasing their respiratory rate to compensate for that, then yeah, Chief is absolutely 100% right.
But it absolutely does come down to why would a BLS provider put end-tidal CO2 on a patient? And the answer is that number one answer is sepsis. Why would a BLS provider be able to interpret CO2 capnography? The most common event is ROS identification during a cardiac arrest. So it's still a very useful skill.
Yeah.
Hey, Dave.
Oh, and it's done.
Yeah.
Just a quick question, going back to the sepsis. Now, you were saying that it would be with patients with high temperatures. Now, with sepsis, you can also run low temperatures. Would that change it also?
Yeah, the patient I just described earlier, she was actually cool to the touch.
Yeah, see, when I had sepsis 2 years ago, I was below, my temperatures were very low. And
so I have the protocol right here. I pulled it up to see the exact reading. I knew it was a low end-tidal CO2, but I can read it off here. So to qualify for sepsis protocol in an adult, the patient has to have a suspected source of infection. So they're bedbound, they've had C. diff, whatever. And then at least two of the following criteria. So a temperature greater than 100.4 or less than 95.9, a heart rate greater than 100, respirations more than 25, or end-tidal CO2 less than 32. And the reason for this is the shock state, and then also the respiratory rate is high because when they're sick, they're acidotic, and so they're trying to blow off that end-tidal CO2, which the CO2 in the body's acidotic, so they're trying to compensate by blowing that off. And then they can be hypotensive, less than 90, or a point of care lactate reading, which we don't have, but it has to be greater than or equal to 4.
And when you hit cold sepsis, is when the temperature goes low. You're actually in you've been septic for quite a while. Cold sepsis is actually late stage, so you would expect to see a more profound reading on your EtCO2. I had a cold sepsis patient back in February. This guy's temperature was right under 95, and his end-tidal was at 26.
yeah, mine was like 90, I think it was just below 95 when I had it. And I was I had acidosis also.
Mm-hmm. Yeah, if you see a profoundly low end-tidal CO2 value, like in the 20s, that patient is sick. They're extremely sick, but it's certainly something that you might not have noticed otherwise, or that it would have taken you longer to get to that point.
Well, that's what happened. We didn't know what was wrong with me, and I was even sent home from Savista or Charles Regional the night before, and then the second time I came in, they put me in the fast track.
Yeah.
So the point is, if a BLS provider uses it, it's a matter of training to understand why we're using it. But it certainly is usable if you've got access to it. It certainly is part of protocol if you've got access to it. And the key to it is, what's the judgment call that you would put, instead of putting a nasal cannula on, you would put an end-tidal CO2 measuring device on. And the answer is that you would suspect that there might be something else going on, and you clearly have a very sick patient. So if you've got a normal, a not too sick patient who's not going to do anything that you wouldn't want them to do by the time you get to the hospital, spend $6 on the nasal cannula. If you think that if you have the equipment available and you think it's quite possible that you will gain some information by putting end-tidal CO2 on, you're at liberty to put end-tidal CO2 on. And you can put that end-tidal CO2, put in the nasal cannula, but also put on the non-rebreather. There's nothing wrong with that. You can do that and it works perfectly well.
Yeah, and I will say I use them extremely liberally. I put them on anybody altered, anybody with a respiratory problem, anybody who I'm suspecting sepsis on. I use them all the time for everything, and they're great.
So can I, quick question. About a couple months ago, it was discussed where technically we're supposed to meet 3 of the criteria. And Dave, did I believe
Which criteria?
you're saying that they're now low?
Barry, you're breaking it really badly. I don't know if you can hear us, but we can't hear you. You're freezing.
Barry, it sounded like you were referring to sepsis criteria. Is that right?
Yeah, he's completely frozen. I don't think the
Yes.
internet's very good in Virginia.
Okay. Yeah, it looks like you said yes.
It's,
So
is it 2?
protocol is 2. plus
2
a source of-
or 3?
It's 2 plus a source of infection.
Right.
So, and the protocol book has the exact specifics and the exact language, but yeah, so end-tidal CO2 is one of them. And then, and I guess, it's important to take into consideration the fact that, you can certainly have end-tidal CO2 of less than 32 and a heart rate of, over 100. You could be having a panic attack, but does that mean you're septic? No. So, certainly clinical condition has to factor into it, but it's 2 plus a source of infection.
I'm just looking something up here. Just give me a moment.
And I know we're starting to run late. Anybody else have any questions on anything? I'd be happy to answer.
Oh, and Andrew, when you're done, if there's a file on EMS Planner under shared files that says 2020 Zoom training or something along those lines, if you could upload the file into there so that people can come look at it later, that'd be great.
Sure. Yeah, I want to add more stuff about the acid-base balance in respiratory physiology, but I didn't want to for this because I didn't want to go over an hour. And I felt
make a second presentation on respiratory physiology. You can do it in a couple weeks.
I'm making myself more work. All right, I can certainly do that. Yeah.
So where I was going with that, just for information's sake, and I might get the number wrong, so I apologize if I do, but I believe that they work in 30-minute identification, so a 30-minute delay in treatment of sepsis, I believe has something like it's a very large percentage. I think it may be 10% or higher in terms of mortality. Do you know what that is?
I know I know exactly what you're talking about because all the MedStar computers have it when you look at them.
I know, and I can't remember what the
I can't
remember what the ratio is.
I thought it was 8% every hour. But
So the survivability of your patient for not identifying sepsis drops by, and let's just say 10, and if we're wrong, we'll fix it. But it drops by 10% per hour for every hour that you don't identify sepsis. Well, you're going to have that patient for about an hour. So if you don't create a priority 1 sepsis patient so that you don't get to the hospital and they fart around while they're working out what to do with that patient, and you're hanging on a wall and doing everything else because you haven't declared a priority 1, you can delay that patient's treatment by, on a good day, we could be 2 hours, 3 hours of delay. And that drops potentially their survivability by 30% or more.
Yeah, I just found it here, Dave, from Sepsis
Okay.
Alliance. It's 8%, as much as 8% for every hour. So if we're holding the wall with, what we thought is just, grandma maybe has some dementia or something, and we didn't pick up the fact that she's altered from sepsis, you could certainly, if you sit there for 2 hours, that's a big increase in the
Yeah, so
mortality.
you've just reduced their survivability factor by probably 20 to 30% by not intervening in the sense of creating a priority 1 sepsis patient. So bearing in mind that grandma who was sick, my mum's sick, right? That call, and you end up on the wall and you have no basis for them accelerating that patient at all, because they're breathing, they've got oxygen on, they seem to be fairly quiet. Well, they would be, because they're not mentating very well. Because we've stopped diagnosing and we've stopped thinking about what could be wrong with the patient, and we're not using a tool that may be available to us, we just reduce their survivability by 30%. So that is a direct example, probably the most important direct example of why BLS providers should use capnography.
Yeah,
Does that help?
And if you're going to run, 5 of those patients in your career, hell, you might be responsible for a death if you miss sepsis once. And I know it sounds bad, but, with people taking all these blood pressure medicines that, not only keep their blood pressure down, but their heart rate down, and other things like that, it's hard to pick up sepsis in a lot of cases. So
Barry, you're coming in as B chief. Why don't we take a look at reviewing what equipment we have, make sure that your providers know what they've got and know when to use that equipment under what conditions, because they should be suspicious enough to spend an extra $20 and put an ETCO2 on. How about that?
I totally agree with you. I mean, I think it's a phenomenal. I mean, I've used this tool before, and I just find that it's such a cool tool to use. To be honest with you, I didn't know about the sepsis part because we were never talked about that. But since you bring this up, it's such a valuable tool that we should spend more time training. So instead of just a couple of our BLS providers being on this call, have another in-session training with us, because I did not know that this was a primary tool could be used to help determine sepsis. I only knew about the CPR.
It's actually the only primary tool.
Right.
We don't have another tool which gives us a direct vector to sepsis. Everything else is a combination of things.
Right, because I mean, I've been pushing all of our BLS providers to get a temperature. I mean, we got the really cool temperature monitor, and it's easy. So yeah, I agree with you. I think this is so phenomenal, because I said I didn't know about this until Andrew brought this up.
Well, I think we only just worked it out ourselves.
Right.
We know about it, but that's because we look at it.
Right.
And I think it's a matter of joining the dots from the point of view of saying, how can we improve that BLS call?
Right.
And spend a few more bucks to make sure that we get this, we don't miss this.
Ironically, I
mean, looking at it as another vital sign. I mean, this is another vital sign that gives us a bigger picture of what's wrong with our patient.
Right. I think it's so cool, because I mean, so down here we do King, and with King we always do the entitle, but I didn't know about the sepsis. I really didn't.
Yeah. So it really is the standard of care. Any breath delivered through any kind of advanced airway monitored with an entitled CO2. I honestly did not know until tonight that it was BLS in Maryland. I was firmly convinced, and I stand corrected.
You know what I would say, and I mean, it's up to Jamie to make this call, but my view is you have the piece of equipment, you're stuffing oxygen up their nose, and whether you're doing it with a cannula and sticking it up their nose with a CO2 line, a cap line, or whether you're doing it with a normal cannula, who cares? I mean, nobody's gonna moan at you. You're doing the right thing in terms of giving oxygen. And if you, in the process, you happen to find out that somebody is a septic patient and you can do a priority 1 sepsis in the process, then nobody's going to have a problem with that.
Yeah. And I think honestly, we're at a point where, you know, it's certainly, like I said, the standard of care for ventilated patients, but, you know, I think it's almost to the point where, you know, it could be considered standard of care for sepsis workup, even for BLS.
Right.
So,
And he's right, but I'm also going to say, understand what you're looking at before you do it,
Right.
because we don't want to, you know, spend an extra $5,000 a year on unnecessary capno lines
Hmm.
just because we're putting them on every patient. We
Right.
did that, we went back from that edge.
Right.
So now what we've got to do is work out how we become smarter in terms of applying the technology.
Right. So Andrew, that'd actually be really good if we come up with a mechanism to say, okay, if you see this patient with these presentation, then use capnography. If you don't see this list of items, then it's not necessary.
I think the way I would prefer to teach it, if possible, is the way I think is I don't like to follow a rigid, you know, if this then.
Right. No, I get that.
So, you know, I think if we, and I firmly believe it's not beyond reach of EMTs. I think if we teach kind of how it works and maybe get a little bit more in depth on, you know, how and why it works, I think
Right.
that then people can draw their own conclusions as to when they
Right.
decide to use them, when they feel like it factors in.
Is it's like, okay, if I've got a person with a broken ankle, do we put capnography on? Probably not. I mean, that's kind of thing. That's what I'm kind of looking at is like, you
Yeah.
have a sick person, follow these, you know, start looking at this.
I'll
Because
certainly, I can spend some time and I'll definitely try to come up with something for sure.
Right.
Unless they broke it 2 weeks ago and they've got a hot
Right,
mess.
like
Right.
because
No,
beyond,
seriously, I
yeah,
mean,
there you, yeah, you're right, Dave. You're right. Okay, because
But these
ironically,
trainings are making us better EMTs.
right, in reality, I had a patient who was just like this down in Virginia here that I wish I knew about the capnography as far as the sepsis because it was a sepsis patient, but it was a DNR patient. It wasn't a DNR patient, but she was on hospice. It was a total. It really rattled me for the first time. So knowing this would have helped me with that extra step.
okay.
Perfect. Excellent.
All right. Well, we're starting to run long.
I'll get it.
Anyone has anything else?